Jay, do you want to bring us home?
I will. I'm great risk. I'm going to put this down. Yes, these are very low chairs. I'm going to talk from the perspective of the Medicare Payment Advisory Commission, which I chair, MedPAC. Some of you may be quite familiar with MedPAC, some may not. It's about 20 years old. It's an independent commission chartered by Congress. There are 17 members. Usually 4 or 5 are physicians, others from the healthcare industry, economists, academicians, and about 20 very high caliber staff trained in economics and other disciplines. We meet 8 times a year for a day and a half here in Washington and produce 2 formal reports to Congress, one in March with respect to how parts of the industry should be paid going forward, and then one in June dealing with larger issues of healthcare, Medicare policy. So I'm one of the physicians, and I'm actually in a category by myself. I'm a physician who thinks he's an economist, which is only slightly less dangerous than the opposite. What I want to do is talk to you a little bit about a policy that we're in the process of developing. So this is not been formalized yet. We expect it will be, or something close to this will be as part of our June report. No, actually, our March report, take that back. But we have a meeting next week and then another one in January before we finalize that. So take what I say with that understanding. This is not MedPAC policy, but it is the direction that we're going into. And in doing it, I'm going to weave together, I think, 2 themes from the day. One has to do with the issue of physician burden, practice burden. That's an issue that I have worked on in other settings in my life. And the second one is the issue of quality measurement and how that should be done and how it might not be done so well. And you heard a number of, I think, positions this morning, I think, which underlie to a large extent what I'm going to say. So if I get this right, we'll go to the first slide. So this is, we're talking about the Medicare Access and CHIP Reauthorization Act, which is, I think, about 4 years old. Its primary purpose was to repeal the previous way that, or at least its primary purpose for this discussion was to repeal the way that physicians were paid in the Medicare programs. SGR stands for Sustainable Growth Rate, and essentially what it did was it changed, or theoretically changed, the update that physicians would receive in any given year based upon the volume of services that were provided across the country. It was a very ineffective mechanism, quite annoying, I think, to the physician community, particularly the organized physician community. MedPAC had supported its repeal for 10 years. It was finally repealed. But the notion was at the time, so we need to replace it with something. And so it was replaced with 2 new payment tracks for physicians. And these were both designed in different ways to reward value, as we've talked about today. One called APMs, or Alternative Payment Models, later changed to Advanced Alternative Payment Models, is for organized practices. Now, I put that term in quotes because they're really a whole different variety of practices which qualify, CMS qualifies as APMs, but they're more organized than not. And for physicians who are not in those settings, Congress developed another payment system called the MIPS. I have that underlined because that's the part of the payment system that I want to concentrate on, and that's the part that MedPAC is preparing a recommendation for. So the notion here is for physicians who are not or cannot be or don't want to be in alternative payment models or can't get into one, which is, I think, a problem that we heard a little bit from Kate about this morning. The notion here is that physicians on an annual basis would be assessed individually by CMS based on 4 areas of performance. Quality, which is currently rated at 40%, will go up to 50%. in 2020, 60% going up to, down to 50% in 2020. Advancing care information, read electronic health records, et cetera, 20%. Clinical practice improvement activities, both in terms of efficiency and process improvement to support quality, at 15%. And then cost, which is set at 0 for the 2019 payment year, which is based on assessments made this year in 2017, going up then to 10% in 2020. The notion here is that CMS, based on information that the physician reports for the most part, and then some cost information and satisfaction information that CMS develops itself, would receive 2 years later an increase in payment for each service delivered in fee-for-service, or a decrease in payment based on the scoring system. And the increase or decrease starts at 0, and eventually after, I believe, 4 or 5 years, reaches 9%, or an 18% difference between the lowest performing physicians and those performing at the highest level. That's a significant amount of money for physicians. So we have been looking, MedPAC has been looking at MACRA, both at the APMs and at MIPS now for over a year, and trying to formulate recommendations for CMS, and also potentially recommendations for the Congress with respect to how CMS might choose to implement it, but also potentially how Congress should consider changes to the MACRA legislation. And we are in the process of coming to the conclusion that the MIPS branch is probably so broken that we think it's not viable and needs to be repealed. This has been popular in some settings and not in others. Why? 2 reasons. I'll focus first on the physician parts of this, the physician burden. CMS itself has calculated that across the country, for those physicians who are going to be reporting, and that number keeps getting lower all the time, it'll cost about $1 billion for physicians to actually access this data, report these measures, and then maybe about $800 million a year after that, because the first year is a little bit more costly. MIPS reporting is extremely complex. In fact, there are, first of all, exceptions, as I mentioned. CMS, for various reasons, mostly based on the volume of services provided, that is, how many Medicare beneficiaries are cared for in an individual practice, and also the volume of charges, and CMS has been changing that. Estimate now that about 850,000 or 57% of those who are not in APMs will actually be exempt from MIPS and therefore receive no payment for managing cost or quality at all, payment increases or decreases. There are multiple and complex reporting requirements. The score, which is a complex, as you might imagine, just looking at that previous slide, is a complex both reporting and mathematical computation. Largely, I think we believe in the end will be pretty opaque to most physicians. And our observation is, although we have a difference of opinion within the profession itself at the moment, that many physicians in the end will be quite confused by this system and unhappy as MIPS rolls out to its ultimate 18% payment gap among physicians. But more than that, as it's currently constructed, it's pretty unscientific. There's several hundred process measures involved if you're going to do individual measurement for each physician, and we have scores of specialties. You're going to need a number for each specialty, so you're in the range of hundreds of measures that are potentially reportable. Very few of them are evidence-based and linked to outcomes. There's also the statistical problem that Bob Berenson talked about this morning. That is, it's very difficult to find, there are few, satisfaction perhaps being one, surgical outcomes in some cases being another. But for the most part, it's very difficult, even over 1 or 2 or 3 years, even over 2 or 3 years, to get statistically significant values by physicians because of the problem of small numbers. Now, that problem of small numbers may be one thing when you're talking about coaching physicians over a period of time. It's quite another thing, I think, for physicians who are in practice when you're going to, CMS is going to change their income arguably in the range of 18% based on that performance. Physicians choose their own measures, which in some ways is good. It's, I think it's helped the acceptance of the program on the part of some physicians. But since every physician is going to be choosing his or her own measure, but then you're going to be comparing those physicians to determine who gets payment or not, it makes very little sense, right? I mean, you then win not based on your performance, but how clever you are in choosing which measure you're going to get. And also, as we've looked at it in the short to intermediate term anyway, MIPS appears to be structured to maximize clinician scores. And that's going to do 2 things. In the short run, it's going to be like Wobegon. Everybody will be doing really well. The net result of that is that there'll be $1 billion worth of work produced in the first year to move tiny bits of money since everybody's score is really close. And the range of, as I said in the beginning, the range of change of payment is very small. A lot of work for essentially no gain or significant loss. However, in the longer run, once we get to 9% up and 9% down, and we still have compression of measures and differential measures, you're going to have a swing of potentially 18% among physicians based upon, again, potentially very small differences, or differences based not on the fundamental science here, but based on gaming of the system. So rather than just give you problem definition, I'm going to potentially propose a solution, because that's where we are going right now, although, as I said, there's a certain amount of heat involved with this potential direction. And that is to essentially, if we get there in January, recommend to Congress that MACRA, this portion of MACRA, be repealed, and MIPS be entirely eliminated, and the reporting by individual physicians and that cost and work burden be removed. And instead of that reporting system, that we would create something new called, we're calling it the Voluntary Value Program, VVP, building on some work that we did and reported in our June report to Congress of last year. So what would this be? So this would essentially be a budget-neutral program. So there would be a withhold, or whatever you want to call it. It could be front-loaded or back-loaded. And we're talking about 2% of the physician payment stream at the moment. I've heard arguments for making that larger, but that's where we are right now. And so physicians then would have a choice. They could either join an AAPM, and we would hope, and we have urged CMS and potentially Congress to make AAPMs accessible to as many physicians as is possible. Or they could elect to be measured by a group or set of physicians of their choosing. The only argument, the only stipulation so far is that that group of physicians needs to be large enough in order to get statistical significant reporting. And we're still in the process of working on what those numbers would be. Certainly it would apply to most medium and large group practices, whether those are single specialty or multi-specialty. It would probably certainly apply to most hospital medical staffs. It would probably apply to county medical societies. And we think that based upon the evolution of this idea, it would not take very long for organizations to provide help to physicians to create these entities. This is a voluntary association of physicians. It's not a new idea. In fact, a small portion of the MACRA bill in MIPS included this option, but it has not been taken up widely by physicians so far. The notion is then, or physicians could choose to do nothing, and then the withheld money would be used to pay other physicians who do accept this accountability.
Jay, I'm guessing there may be some questions, so if I can get you to skip to them. Thanks.
All right. So in other words, at the end of the year, the physicians will be measured not as an individual, but as a member of this entity. The entities would then receive reward or not based upon their accountability. So what are some of these measures? I'll let you look at these. These are basically population-based measures, closer related to outcomes than some of the process measures that are currently employed. They would be calculated, though, from claims for the most part, and surveys that Medicare itself would do. So the physician reporting would go away, and the burden that we described would go away. And then I'll just conclude by saying what I said in the beginning. MIPS is not sustainable. It has too great a burden on physicians for no particular benefit. It will not, in the end, identify high and low value clinicians. CMS is actually scoring or receiving reports from physicians this year for payment in 2019. And so why are we doing this now? We're doing it now because it's already underway. And from our perspective, if we wait and watch this play out, there's going to be a lot of money, time, and effort expended. And despite the controversy, this is time to call the question. We think also there are positive outcomes. Our policy option will encourage clinicians to join other clinicians and begin to think about this notion of assuming collective responsibility for the outcomes of their patients. Many physicians do this, but not all. And it will allow Medicare to adjust physician payment based on population-based outcomes that have statistical validity at the entity level.